session on aneurysms. Aneurysms, by definition, are localized dilation or outpouching of an artery due to weakness of the tunica media. Complications of these aneurysms are thrombus formation and thromboembolism, rupture and hemorrhage, dissection, and compression of nearby structures. They're categorized by location, etiology, and morphology. With respect to AAAs or abdominal aortic aneurysms, the location, self-explanatory, abdominal aorta between the renal arteries and the bifurcation below. Etiology is typically atherosclerosis or hypertension. Fusiform in morphology presents as asymptomatic pulsatile mass. Rupture presents with severe back pain. Here is an example of an abdominal aortic aneurysm. You can appreciate the dilation in between the renal arteries and the bifurcation on the left there, and you can appreciate the extensive atherosclerosis involving the side walls there of the aorta. Syphilitic aneurysms, typically located in the ascending aorta, caused by tertiary syphilis, which leads to endarteritis obliterans of the vasa vasorum. Morphology is also fusiform. Clinical features include aortic regurgitation from dilation of the valve ring. Another entity is the dissecting aortic aneurysm. This can occur at all levels. It can be most problematic when it involves the ascending aorta. Etiology includes hypertension, Marfan syndrome. Both cause cystic medial necrosis. Blood dissects between the intima and the media through an intimal tear, and flow enters into this false lumen, creating further dissection down the aorta. Clinical features include severe stabbing chest pain that radiates to the back and may rupture into the pericardium, causing pericardial tamponade. Here we have the arrow pointing to the area of cystic medial necrosis of the aorta, which makes the aorta more vulnerable to dissection. Buried aneurysms are located typically in the circle of Willis. These can be congenital or associated with adult polycystic kidney disease. They can be associated with hypertension. It's a saccular aneurysm. Clinical features include the classic worst headache of my patient's life because these buried aneurysms that rupture cause subarachnoid hemorrhage. A question, a 20-year-old male develops sharp, severe chest pain. Chest x-rays show a widened mediastinum. Transesophageal echo shows a dilated aortic root with an intimal defect 1 centimeter distal from the origin of the great vessels. The etiology of this disorder is most likely, this is a typical picture, so a young male doesn't have any atherosclerotic risk factors and no other symptoms suggest another etiology is likely has an aortic dissection secondary to genetic causes, so D would be the right answer in this circumstance.